Hello, I'm Dr. Jim Del Rosso, the editor-in-chief of Clinical Dermatology of the Journal of Clinical and Aesthetic Dermatology, which we affectionately refer to as the Green Journal, the JCAD. And I'm very, very happy to be able to bring you issue highlights from the June 2025 issue. And so let's get right into it. I think it's great that the journal is getting more letters to the editor, and there were two this month. And the first one was from Peter Leo, that got together a group of other authors to combine what's going on in Colorado, West Virginia, and also Chicago. So remember, Colorado and West Virginia, if you think about that song Rocky Mountain High by John Denver, talks about Colorado and West Virginia. I don't know where Chicago fits into Rocky Mountain High, but obviously Dr. Leo's there. So this was a great collective effort that talks about systemic cryotherapy as a potential therapeutic option for mild to moderate atopic dermatitis. And it's a letter to the editor that also has a table that summarizes whole body cryotherapy, but they also talk about localized cryotherapy. So don't think about this like we're using liquid nitrogen cryosurgery for actinic keratoses or warts. This is utilizing the idea of exposing the skin to the cold to override the sensation of itch, which actually makes sense because I know sometimes when we had a lot of difficulty with prurigo nodularis lesions that are intensely pruritic and really uncomfortable with burning, that we would sometimes utilize liquid nitrogen cryotherapy by spray to those individual lesions to do whatever we could to combat that itching. So this is a very nice letter to the editor that reviews uh, really looking at how you can utilize localized cryotherapy and even ways to utilize full body cryotherapy exposure, liquid nitrogen exposure to reduce itching. I think it's very valuable and could be very helpful to patients that are having trouble with severe pruritus. There's another letter to the editor that comes to us about a colorimetric scale for evaluating skin of color, individuals with darker skin, to improve upon what we've used for years, which is the Fitzpatrick skin type evaluation. And quite frankly, the Fitzpatrick skin type, it's been around for a long time. I think it's been around since like the 1970s. And it's supposed to be based on looking at how we evaluate the reactivity of the skin to ultraviolet light exposure. Originally developed, it was in 1975 actually, to look at how we would gauge exposure to ultraviolet A. And it's been passed down the line as the way to characterize patients so we can put them into categories of their skin pigmentation. But it's not only to be looking at somebody and putting them into one of the six types based on the descriptions, six being the deepest skin pigmentation. I always think of the singer Seal, how dark his skin was, as being a Fitzpatrick type 6, and someone extremely fair, white, like somebody from Northern Ireland, being Fitzpatrick skin type 1, and we have grades in between. And we typically would look at people and judge them based on the appearance in their skin and where they fit in. And you can see that there would be a lot of variability, what someone might call a two, someone else might call a three or a four, but that's pretty much how we've done it. Well, this is a scale that is much more accurate to try to really look at the skin. We call it types, but we're not really describing types in terms of how skin reacts. We're just basing it on the color appearance of the skin. And this colorimetric scale is being suggested as a way to improve upon that. It is shown here very within very nice graphic, and I think these individuals are onto something. So I something that's worth looking at. And obviously, pigmentation and how we grade it is extremely important as we have more and more individuals in the United States, not only Black or African American, but they can be Indian, Asian, Middle Eastern, or other races and ethnicities that have darker skin, not just very fair skin. Even some Caucasians tend to have some darker skin. So it's a very, very important letter to the editor. I'm happy that we're getting letter to the editors. This journal is really moving up in the eyes of dermatology. On a weekly basis, I get emails, and I'm very happy about that. So there's a very good paper that I think is really important and very interesting that the senior author is Dr. Amy McMichael from Wake Forest University School of Medicine. And that's where all the authors are from on this paper. And the paper discusses the current state of patient adherence to lab monitoring guidelines for Janus kinase inhibitors, knowing that these oral Janus kinase inhibitors have box warnings and there are recommended guidelines in the package inserts that clinicians, it's suggested to them that they should absolutely follow these guidelines or something close to them based on what they think is relevant in the clinical practice. And so they uh, looked at patients in a specialty clinic where they're treated for alopecia areata, a specialty hair clinic, and a retrospective chart review of patients seen from 2021, January 2021 through May 2024. And really what they were looking at, they were checking for the adherence with laboratory monitoring every 3 months and assessing how many patients had this every 3 months in accordance to the guidelines so that they're followed, on a regular basis to look for laboratory evidence of adverse events. And interestingly, there were many patients that did not follow closely enough, and some missing a lot of the visits to stay on schedule with those laboratory monitoring guidelines. And this is at a very respectable facility. It's hard for all of us to stay on top of everything our patients are asked to do and making sure they follow up with them. So it's a way to look at this more closely to try to develop systems within our practices to stay on top of this because patients don't necessarily listen. Now, these are alopecia areata patients. They tend to be younger, they tend to be healthier in most cases, and it doesn't necessarily click in their brain why they even need to have these blood tests. And sometimes you may be testing for other things. Maybe you're testing thyroid testing over some other comorbidity. So I think this is very worthwhile for all clinicians because the majority of us are utilizing Janus kinase inhibitors for our patients, oral and also the one topical that we have available. But this is specifically talking about oral. The next is a very interesting paper. Valerie Callender is the lead author, but there are individuals in dermatology combining from Salt Lake City, Philadelphia, Durham, North Carolina, and Washington, D.C., where Dr. Callender practices and is involved also in teaching at Howard University in dermatology, but has her private practice there. And it talks about established and emerging laser treatments for acne vulgaris in diverse skin types. And we know and have seen a lot of physical modalities, especially lasers and lights, that are used for the management of acne over and above the medical therapies we have. Sometimes these are needed for certain situations, but the vast majority of the time, they are out of pocket expense. So it's not always that easy to integrate, but still many patients are obtaining these therapies to get more of a response over and above their medical therapy, or maybe there's reasons why they're not utilizing different medical agents, both topical and oral, for acne vulgaris. They basically show in a very nice table, table one, summary of studies since 2016 on the subject area. And there are 20 studies that include a total of 642 patients. And what is really the biggest limitation is long-term follow-up to evaluate the response to these therapies. So we do have uh, approaches that many of us that utilize these different approaches in our practice, various different laser systems, for example, especially some of the recent ones that have targeted more, acne, at least based on our anecdotal experience. And the studies we have show them to be very effective, but we still need more long-term data. So this is where we really have to drill down and try to get longer-term data for these devices so we can differentiate them both in the short term and in the long term. I think a very, very helpful study. Now, another paper that is actually on a subject that we've seen recently in another article that my good friend in Houston, Ted Rosen, has been a part of. It's on the efficacy of complementary and alternative medicines utilized in cosmetic and surgical dermatology, a comprehensive review. And there's no doubt that many of our patients, and I think for very good reason, are looking for complementary and alternative medicines for a variety of different situations that we treat in dermatology. One that I could think of that we address in this article is the use of silicone patches or silicone gels to reduce scarring and reduce keloids these are available over the counter. And my impression is they've been very helpful in many patients if properly used, but there are also some suggestions about how to use them optimally. I'm not big on buzz phrases like unmet need, but this is definitely an unmet need. We need more data. We need more studies that evaluate these complementary and alternative medicines. We don't have many randomized controlled trials, and many of them are, they don't give us the best results. That their design is not always optimal. But we have to remember these are not pharmaceuticals. These are over-the-counter products, and we don't necessarily have an organization like the FDA does on pharmaceutical studies to keep us within a fairly tight knit range of how the studies need to be done and how the outcomes need to be shown. So hopefully we can get some leaders in this area to get together, people like Dr. Rosen. Another name that comes to mind, I think, is extremely important in this area and is a leader in integrative dermatology, is Dr. Raja Sivamani, who practices in the Sacramento area. He is the medical director and editor of LiveDerm that gives a lot of education. He runs an integrative dermatology meeting and publishes a lot. Maybe there can be a group that gets together and tries to give some advice. Of course, there are good therapies out there. It's just hard, hard to herd them all in one place and to get that higher quality of evidence. But certainly, these therapies are very, very helpful for many patients. There are some other articles we don't have time to review. There's physician and trainee beliefs and comfort regarding psychodermatology management, a cross-sectional survey from a large tertiary care center facility. Psychodermatology is certainly something that we deal with in dermatology on a fairly regular basis. It's challenging to us. It's sort of something that many clinicians have difficulty with or staff. So we need all the help we can get because our patients have minds as well as what's happening on their body, on their skin. And also another paper, Multidisciplinary Dermatology, a framework from the Association of Academic Cosmetic Dermatology. As you can see, there are a lot of groups trying to bring together and get more structured in how information is brought to the masses in dermatology. Another paper I think is very interesting, and one of the things that I focused on as editor in chief of JCAD is to get more case studies that are instructive, that tell the clinicians in the trenches and their staff certain cases to be illustrative to help them get better at managing the disease, talking to the patients, and treating the patients. And this is refractory acrodermatitis continua of Halipo, which is basically a digital psoriasis in a pediatric patient underlying mixed connective tissue disorder. So it's always very interesting when you see specific entities to figure out, why was there some thought in the clinician's mind to look further in the patient. It's either something they see, very often something they hear in the history, but you have to have the ability to obtain that information in the history, which is not always easy to do in a busy day, in a busy practice, whether it be in the community or at an academic facility. So that really caps it off. There are some other pieces of information and things that are written in the journal. I can't go over every bit of it, but I hope you do. And thank you very much for tuning in to this journal highlights for June 2025, JCAD. Hopefully, if not already, becoming your favorite peer reviewed and indexed journal in dermatology. Thank you.